Assalamu alaikum, the long clinical consultation day. First scenario, Mrs. Julia Smith, 35 years old, a female patient with a complaint of recurrent dizzy spells. Please take history and examine her. Here you go.
Hello, I am Dr. Muhammad. I am one of doctor today. May I confirm Ms. Julia Smith, 35 years with me?
Yes, I'm Julia.
How are you, Ms. Julia?
I'm okay, alhamdulillah.
Can you tell me today we'll discuss some health issues for you. I will take some history and do some examination. All our talk will be confidential if you don't mind. Okay?
That's fine.
Can you tell me in your work what brought you today to the clinic?
Yes, doctor. In the past 2 months, I've been having these times when I feel really dizzy. I feel so lightheaded.
Sorry for that, Miss Julia. So dizziness with light-headed. Okay?
Yes.
But suddenly or gradually?
No, it just happens suddenly sometimes.
The last time when?
Last time, 2 days ago.
Okay. Any trauma or when you feel this dizzy?
No.
Did you feel it's increasing by?
No, doctor. It has been the same since 2 months.
You notice anything increased like standing from sitting or up or long standing or anything increased?
No.
Anything decreased when you are rest or
No.
specific time in the day?
What?
This happening in a specific time in the day?
No, it can happen at any time.
Yeah. Last time, what you were doing at this time?
I was watching the TV.
Okay. Did you lose your conscious?
No.
Okay. Any feeling of sweating at this time or hunger pain or
Yes, usually before of these times of dizziness, I feel like I'm so hungry and I'm sweating.
okay. Anyone check for you your glucose?
Yes, it was checked once at work. It was found to be low.
Okay. Improved after taking some candy?
Yes, I take juice sometimes.
Okay. You feel any shaking on your body?
Yes, with this dizziness, yes.
Okay. Does this happen before this 2 months before?
No, never.
Okay. Okay, Ms. Julia. You feel any heart awareness at this time?
Yes, sometimes.
Was fast like this, regular or slow?
No, it was regular.
Okay. Any chest pain with it?
No,
Okay. Any feeling of weakness in a part of your body?
no,
Any feeling alter sensation?
no,
Any balance problem?
no,
Any change of your speech?
no,
Any change swallowing?
no,
Okay. Any vision problem at this time or
no,
before?
no,
Any headache?
no headache.
Okay. Any increase of blood temperature?
No, doctor.
Any neck stiffness?
No.
Okay, that's good. Did you notice any change of your weight nowadays?
Yeah, it increased a little bit.
Increased.
Yes.
How much?
Like 3 kgs over the last 2 months.
Okay. What about your appetite?
My appetite is not changed.
Okay. So it was intended this way, increase was not intended.
No.
Okay. Okay, Miss Julia. Any weather preferences?
What?
Weather preferences?
No.
Okay. You notice any lump or bump in your body?
No.
Any joint pain?
No.
Any back pain?
No.
Any rashes or skin changes any part of your body?
No.
Okay. About this weight, it is a specific site in your body, or you feel all over your body?
No,
Like
it's all
in the
over
back,
my body.
all over?
Yes.
Okay. Okay. Okay, Miss Julia. What about any past medical history, long-term condition or disease you have?
No, doctor.
No diabetes, no hypertension,
No.
any medication?
No.
Okay. Any family history? If not, I need to know.
What do you mean exactly?
A gland problem, any cancers?
No gland problem, no cancer.
Any surgery or procedure?
No.
Okay. Miss Julia. Any allergies?
No.
Okay. Any travel history soon?
No.
Any blood transfusion?
No.
Any, sorry for this question, any using of illicit drug?
No.
Juliana. What about you are married?
No, doctor.
Mm, any cause for this, or
No, what?
any specific cause?
No, doctor.
Period is okay?
What?
Period.
Yes, period is fine.
Miss Juliana, I will ask some question كده fastly. Any chest, I asked before any chest pain, right? No, you mentioned no.
Yes.
Okay. Any shortness of breath?
No.
Any cough or phlegm?
No.
Okay. Any tummy pain?
No.
Any change in your water work?
No.
Any change in the color or amount or frequency?
No, never.
Any bowel work changes?
No.
Okay. Any swelling in your leg or anywhere?
No.
I mentioned before no rashes, right? No rashes or skin changes.
No.
Can I examine, please?
Yes.
Firstly, I need generally how's the appearance of the patient? Any obese or overweight? Or
Not overweight.
what about her hand? Any sign of anemia or leukemia? Any rheumatology stigmata deformities?
No.
Okay, I will see skin trigger and sign of dehydration.
No.
Okay, pulse is volume and regular.
Pulse is normal.
Okay, blood pressure standing and lying. Any change?
No change.
Okay, any tanning or increased tanning of the skin?
No.
Okay, skin no tightness in the skin.
No.
I will do barometer drift. Any positive?
No.
Okay. Proximal myopathy. I will ask her to stand without support. She can.
Yes, she can stand.
Okay. What about any pallor, any jaundice?
No.
Okay. Any mouth sore in or pigmentation inside the mouth?
No.
Noses or
What?
noses.
Noise?
Noses.
Cyanosis, no cyanosis.
Okay. Lymph node, anterior cervical, cervical, and supraclavicular.
No lymphadenopathy.
I will ask her to swallow to see any swelling in front of the neck.
There is no swelling in front of the neck.
We will do full exam for the heart in the apex site and the S1, S2. Any murmur there?
No murmurs.
First aortic area, any murmur?
No.
Okay. In the carotid area, I will see any berui there.
No pruvi.
Okay. I will examine the back of the heart, inside the back of the chest, any beta rails.
No.
You will examine abdomen for any masses, especially the left side for spleen and any in the epigastric.
No, there is no abdominal masses.
Okay. In the lower limb, in upper limb, are you checking any rashes or any sweat?
There is no rashes or swelling.
Okay, peroneal drift.
No.
I will do firstly one sensory and one motor and one reflexes and the position.
All normal.
Or normal. Okay. Okay, Ms. Juliana. Any past travel history? So,
No.
any tattooing or birthing? Sorry for this question.
No.
You mentioned before no illicit drugs, right?
No.
What about your job? What is your job?
I'm a nurse.
You're a nurse. Okay.
Yes.
How much does affect your job?
It's affecting me very much because it happened many times at work.
Okay. Sorry for that, Ms. Juliana. We will be support you if can we give you some sick leave until we fix it. Okay. Do you
Okay,
drive?
thank you, doctor. What?
You drive?
Yes, doctor.
Okay, Ms. Juliana. Until we fix this problem, please, I advise you strongly to stop until we fix it. Okay.
Okay, doctor.
Any smoking?
No,
Any alcohol?
only socially.
Okay. Ms. Juliana. Also, I need you to moderate or it until fix it because it affect the condition strong. Okay.
Okay, doctor.
Any other information you need to share with me?
No, doctor, I think that's all.
Yes, yeah. Thank you. Thank you. What is your concern?
What's wrong with me, doctor?
I appreciate your concern, and after history and examination, I have one possibility of disease. This is overgrowth of one gland in your abdomen called the pancreas, and this is responsible. This is called decreasing in
Your
your
voice is breaking, doctor. I cannot hear you.
I'm telling I appreciate your concern, and after taking history examination, I have one condition called insulinoma, and this is so one causing increase one protein called insulin, and causing decreasing your glucose level. The symptoms. Okay, Ms. Juliana will admit you and do some investigation and imaging and lab, and and for now, I strongly advise you to stop alcohol or stop driving. Okay.
Okay, is it cancer, doctor?
I appreciate your concern and sorry to tell you. Yes, this is one of the cancers, and we will plan doctor and oncology doctor with us. And once we confirm it, we'll now we need to have an investigation to confirm.
2 minutes left.
Okay, doctor, my mother has diabetes and she has some episodes like this. Is this the same? Do I have diabetes?
I appreciate your knowledge. And one of the possibility, sometimes it can be a early type of diabetes. Also, we send some lab to confirm this. But it also is one of the possibilities.
Okay, doctor, thank you.
Ms. Juliana, what about your mood?
I've been very stressed because of my job.
Sorry for that, Ms. Juliana. And
What?
any support you need.
No, I think I will get over it, hopefully.
Ms. Juliana, you are sure no any by mistake taking any diabetes medication by mistake from mother or from your
No, doctor.
any other concern?
No, doctor, everything is clear now. Thank you.
Okay, thank you.
Okay, Dr. Muhammad, if you can fix your connection because there is as Dr. Kotov said, there is some breaking in your voice, okay? So we can start examine question.
I will try the other.
Okay, please. Once you're ready, let us know.
Okay.
Yes, you can start now, Dr. Kotov.
Okay. So, doctor, what's your differential diagnosis?
After taking history, our patient, female, 35-year-old, has repeated hypoglycemic attack in view of repeated shaking and sweating and hunger pain, and checking her RBS, it was low. So, and in view of increasing weight, my first possibility, it will be insulinoma. Second one, in view of her previous family history of diabetes, also maybe early type of diabetes mellitus. Third one, maybe drug induced because of her mood and stressful condition. I need to check again her some level of insulin and C-peptide for her.
Okay, doctor. How are you going to investigate this patient?
Firstly, I need to check her RBS now, and I will do besides the basic lab of CBC and the SR-CRP and basic panel of liver and kidney. I need to do one ABG and to rule out any diabetes ketoacidosis and check RBS, and I will do full electrolytes. Then I will do ultrasound, also insulin level and the C-peptide level to differentiate between drug from iatrogenic from insulinoma. I will do ultrasound abdomen and CT abdomen, CT pancreas. Okay.
Okay. So, doctor, suppose this patient complained of headache and blurry vision. What will be your top differential?
If there is headache and blurring of vision, I will think about MIN1. I will confirm by doing the visual field. If there is bitemporal hypoanopia, I will go on to check insulin. I will go to check insulin like growth factor and glucose tolerance test and MRI brain. I will check for other gastrinoma, other association of MIN1.
Okay. So, doctor, you said one of your differentials is that this patient is taking exogenous insulin from outside, from her work, for example, or her mother. How are you going to differentiate between true insulinoma and exogenous insulin?
A differential, it will be in insulinoma, C-peptide level will be increased with insulin, and but in the exogenous or iatrogenic, it will be C-peptide normal and insulin level will be high. And if not insulin, you will check for the drug level, the common drug level for diabetes.
Okay, that's great. So, doctor, how are you going to treat this patient?
I will admit the patient for 72 hours at least to observe I will do 72 hours observation for glucose. Once confirmed that's hypoglycemia, that this is the cause, and I will share the endocrine and oncology, and after confirming. It will be surgical treatment, and we can start octreotide long-acting. I will education and counseling for the patient about the disease to make sure that he know about these symptoms, and I will advise for bracelet for her, and to inform her family or the beside person to know about this, to help her once she has these symptoms, and to have some candy in her pocket once she to take it and check her drug level, her RBS glucose level.
Okay, so what is the definitive management of insulinoma?
Surgical and recurrence to octreotide long acting.
Surgical management. Okay. That's it, doctor. Thank you very much.
Thank you.
Okay, what other medication can be given to the patient? Last question, because 5 minutes already.
Other medication beside octreotide long acting.
Yes. Any pen to be given?
Glucose pen or glucagon pen. Sorry, glucagon pen.
Yeah, glucagon pen. Okay. Okay, thank you, Dr. Muhammad. Dr. Qutuf will comment, then I will comment.
Okay, so doctor, regarding the history, at first you got the hypoglycemia early, but you danced around the subject before getting to the causes of hypoglycemic attacks. And then you started to rule out the MAE1, but you weren't organized. You did the full past family history, past medical history, and social history. Then you came back to the systemic review. Okay, but at the end you got the diagnosis by asking about the occupation. This is the differential diagnosis. And regarding the examination, it would have been nice if you asked about the RBS, or asked to do RBS, bedside sugar test, to check what you are dealing with now. If the patient now is hypoglycemic or no, you have to act accordingly. And regarding the past history, you have to ask specifically for any past history of high blood sugar or any past history of diabetes and any family history of diabetes, because you caught this one in the concern, because she volunteered to tell you that her mother is diabetic. Okay, and I think that's it. I didn't write anything else. Thank you very much, doctor.
Yeah, thank you, Dr. Qutuf. It's a good comment regarding you have to rule out the men from the start. I think you
Yes.
asked some questions related to them, the headache and vision problem.
Headache, the vision problem. I asked it. I'm sure.
Yes, I know. The tummy pain, did you ask about any abdominal pain or tummy pain?
Yes. And the swelling. I asked it.
Yes. Oh, yeah. Okay. A change of the bowel habit for also gastrinoma. There is diarrhea.
Yes,
Yeah.
and for hypercalcemia as well, because the main one is parathyroid, pituitary, and pancreas. You asked about the pituitary and the pancreas, but also you have to ask about hypercalcemia symptoms
I
together.
asked about bowel work, water work, if increase the frequency amount. I asked. I'm sure.
Yes, and any if
It
there is
is
any
men
history
really.
of
I thought it is
persistence.
men, not insulinoma from the beginning.
Yes, yes, but what I'm saying is that once you get the hypoglycemia episodes, you have to put differential in your mind. For example, Addison disease, insulinoma, MEN1. That's why you have to rule them out, and then you have to ask if she has any history of family history of diabetes. You ask if she has family history of gland disease or cancer. That's great for MEN1, but you have to ask specifically for any family history of diabetes.
Okay. One more comment regarding the hypercalcemia. You can ask, are you feeling thirsty? It's a combined question or question for two conditions, the diabetes and hypercalcemia, plus, of
Yeah.
course, the polyuria. So you can add them to your scheme whenever you are asking about min1 or hypercalcemia or diabetes. Okay, you ask about anyone checked your blood glucose, and actually they are checking blood sugar. So glucose is as the jargon, yeah.
Right.
Yeah, any possibility to be a cancer doctor? I think it's adenoma, right?
Yes, adenoma, but it's very rare that it's a cancer.
Yeah.
But it's mostly adenoma.
Yeah, so yeah, there is possibility. However, we have to do some blood tests and some scans to confirm is it cancer or no. I think this is regarding the differential. Yes, I don't think you can put exogenous insulin as differential, or you can put as third differential. So the second differential, as Dr. Kotov said, will be min, because they are asking about the common topic in PACEs or hypoglycemia causes in PACEs. So you can say min 1 and Addison also as well. It would be the second. Okay, later on, if he asks you, what do you think more, doctor? You can say the other, because it's not common to be presented in PACEs. The patient is taking her mother medication or taking as a suicide. I think you ask this question intentionally at the end.
Stressful condition.
Yeah, it's a good question to know if she is having any suicidal thoughts. It's
Yes.
good to
And
ask, but I don't.
I should add Dr. Basim in the group psychiatry. This is very important, really, because this is common in nursing to take this.
Yes, you're right. But as a differential, you can put them third after
And a lot
min.
of yes,
Yeah.
yes.
Okay, this is my comment. You want to add any comment, Dr. Kotov?
No, that's it. And I just want to say, like you said, and even in the real exam when this case appeared, this concern about her mother medication was asked by the examiner. It wasn't like an official differential diagnosis, but the examiner asked if you think that her mother is diabetic and taking sulfonylurea or insulin, for example, has anything to do with the case. So it's just it's not like an official differential diagnosis, but you can put it to one of the last differentials.
Yeah, it's not common. As I said, you have to put the most common as a presentation, also as a topic in PACEs. Main one is very high topic and they like this topic. Whenever you put it in your differential, the examiner will be impressed by this differential.
I have a problem, Dr. Basim. Usually, I am excluding the disease. Yani, I asked many times, tanning skin, I check the pigmentation. If the examiner concentrates with me, he will know that I am excluding Addisonian and excluding min. I asked
But when
all in one, but the problem at the end, I am forget. Usually, if negative all signs, I am not putting this, but I have a problem in this.
yeah, unfortunately, they are judging on the differential scale separately. Whatever you did in the clinical communication, they will not put it as a differential scale or
Right.
scale of the differential. So be sure that you are writing the most common differential in your paper, either pre or prior to the presentation or the discussion, or during the discussion, if you can even stop for a while to write your differential. I have to roll out and I can put it as a differential, even after starting the discussion, because they are focusing on these points and the skills will be affected by these questions. Okay. It's a good topic and good performance. And the investigation already mentioned 72 hours supervised blood glucose level. And yeah, please inform the family that whenever you have this attack, they can give you either candy or even the glucagon pen will be accompanied by the patient. In case of bracelet, also can be given. In case of patient found to have collapsed, then they can inject the glucagon. Otherwise, all investigation was done. Don't try or try to minimize this general investigation. Nowadays, they are asking about the specific investigation more than the general. If you want to say something general, try to correlate with your case. What about CBC here? Is it important? I don't think it can add anything, as will add the liver function or kidney function. Addison, you can put, so electrolyte, I should do all full electrolyte. And the EBG, as you said, so to roll out Addison, the patient will have acidosis. Otherwise, the specific investigation, try to start with the specific. Okay. If you start with the specific, so you answer the target investigation. As you said here, the blood sugar, fasting, and postprandial. And if you suspect diabetes, of course. And the 72 hours, a supervised glucose test and fasting glucose test. And the investigation or the imaging of choice will be ultrasound or CT abdomen. If you suspect men, you can add MRI pituitary. Okay. Any question for this scenario? Any suggestion? Any comment, Dr. Kotov, other than you mentioned?
No, doctor.
Okay. Okay, be ready for your case, your scenario about vision issue. I will send you the scenario now.
Okay, doctor.
So Mr. Farouk, 38 years old, has vision problem. His vitals are normal. Examine him and take history. So your patient is male with history of vision problem. 38. Yeah, I
Okay.
wrote it in the chat box. You can see it now. I will go to the comment quickly. Dr. Ayula commented about advice about driving. Perfect. So, and he did it perfectly. He advised her to stop driving until confirming the diagnosis, even until controlling the blood sugar or controlling the disease. Not only suicide, Dr. Ala, not only suicide, but maybe to get attention or seeking sick leave, for example. Yes, it's one of the possibility since she is working as a nurse. Please, what is the complaint? I joined late. This is spells. Okay. Anyone has comment? I always ask the candidate to write sensible differential. And also I'm asking the participant not to look at the chat box in order to give a chance for yourself to test your knowledge. So the other candidate will write in the chat box what are the possible differential, and the candidate who are participating, please try not to look at the chat box, just to make it more interactive, okay? So now we are talking about vision problem. I need please from you to write sensible differential, and we will discuss at the end who wrote a sensible differential. Whenever you're ready, Dr. Kutuf, let me know. Back to the disease spells. Sorry, I didn't comment about the approach. Always analyze it as the before and during and after. Before, during, and after. Whenever you have spells of dizzy spells or collapsing, fainting, all of them you have to analyze as before, during, and after. What you were doing before it, and did you lose your consciousness or awareness? Did you bite your tongue? Did you wet yourself? Sorry for this question. During, what you feel, any sweating, any palpitation or awareness of heartbeat, any shaking, hunger, pain. And after, did you have regained the awareness quickly, or you feel any headache, confusion? Even the movement, are you doing some exercise before it? While sitting, while standing? All this question will guide you to the case, and it will be clear. He will tell you and give you the clue. 3 questions or 4 questions about the before, during, and after, you will know your case. They will not hide. Unless you are not asking the clue, they will hide. Otherwise, if your questions during, before, and after analyze it well, they will tell you the clue. As in this scenario, do you have sweating? Yes. Hunger, pain? So this is hypoglycemia. TIA or stroke, the patient will have, for example, neurological deficit, either weakness in one side or even the disease spells as posterior circulation. Maybe the vision will be affected. And the patient, of course, will have long-term disease or long-standing disease like diabetes, dyslipidemia, AF, awareness of heartbeat. These are the most common. Addison, of course, one of them possible. The patient will have tummy pain, vomiting, diarrhea, along with the hyperpigmentation of the skin. Okay, these are the most common differential, and you have to roll them out. Epilepsy, patient will bite his tongue with himself. The hypoglycemia, as in this case, patient will have feeling of hunger pain along with the shakiness. And the TIA or stroke patient will be a little bit elder and he will have dyslipidemia or comorbidity, diabetes. Or patient already diabetic patient and he's taking insulin without taking his meal. And the Addison, as I said, one of the differential impaces, hypoglycemia as insuloma along with men could be the case, or Bush hypotension case related to the volume depletion or even drug or diuresis patient on, or elderly patient with dehydration. He's not taking good plenty of water. These are the most common dizzy spells in paces. Medication, don't forget it. Patient will be on diuretics, beta blocker. Okay. Of course, the cardiac, one of the most important part, patient either have aortic stenosis, a valvular heart disease, I mean, or even arrhythmias could be the case. Okay. Just I try to summarize most of the common cause. If you are ready, Dr. Kutuf, we can start.
Yes, we can start.
Yes, there you go.
Okay. Hello, my name is Dr. Abdussalam. I'm one of the doctors in the medical unit today. May I confirm that you're Mr. Farouk?
Yes, I am Mr. Farouk, 38 years.
Hello, Mr. Farouk. So I'm here today to ask you a few questions about your health condition, examine you, and address your concerns. Is that okay with you?
Okay, I'm ready.
So Mr. Farouk, could you tell me please what brought you here today?
Yes, doctora, since yesterday I have my right eye. I think it is not okay. I seen many things like double. So I need to check what's going on.
I'm really sorry for what you're going through. So you said that it's your right eye, right?
I
Did it
can't confirm, doctora, but I feel it is like the right. But usually I can't confirm, يعني, what is this?
Okay, so this is the first time you're having such eye problem.
Like double vision, yes, this first time.
Any other eye problem you had it before?
Also, 1 month back, I feel my sight affected temporarily, then I regained it, and it is what like moments.
For how long? For moments only?
Yes,
In the same eye or in the other eye? Or both?
I remember, doctora.
What?
Can't remember.
You can't remember? That's okay. So this one started suddenly yesterday. So it is going, coming and going, or it's the same?
No, no, this is only what happened to me.
So since yesterday, if there is any change in the vision, does it come back or no?
No, the same.
Since yesterday?
Yes.
Okay. Do you have any medical condition I need to be aware of?
Yes, I have diabetes and hypertension, but I am following well.
I'm really sorry for that. Since when do you have diabetes?
5 years back.
5 years. Okay, I will come back to that. So regarding this eye problem, so do you have any redness in your eye?
Mhm.
Do you have any pain in your eye?
Any pain, light pain.
The pain is in the back of your eye or when you move your eye?
I am not sure, doctor.
You are not sure. So the pain just started yesterday as well?
Yes.
Did it come suddenly?
Yes, it's all of a sudden I was okay watching TV.
Okay. Were you watching the TV in a dark room?
No,
Okay. Do you have any similar pain before in your eye?
no.
In a scale of 1 to 10, how severe is your pain?
Four.
What?
4.
Okay. There is any change in the shape of your eye, like drooping of your eyelid?
No. I didn't notice this.
You didn't notice. Okay. So do you have any previous problem in your eye?
As I mentioned, doctor, that only like loss of vision on my side for moments 1 month back.
Okay. Do you follow up with the ophthalmologist, with the eye doctor?
No, I feel it is a simple thing I didn't take care, but this time I afraid it is serious.
Okay. I'm really sorry for that. Do you have any headache?
Headache, like normal mild headache, but not affecting my life. Yeah. I have
Uh,
some stress on my job, but I take some coffee and paracetamol, and I'm okay. Nothing.
Okay, so since yesterday you don't have headache with this eye pain.
No
Okay. Do you have any change in? Do you have any weakness in your body?
weakness. No.
Do you have any change in the sensation?
No.
Any pins and needle sensation?
No.
Any history of fits?
No.
Okay. Do you have? You said you are seeing double, right?
Yes.
There is some side of your vision you cannot see in the sides, for example.
I'm not sure, Doctora. When I move my eye, I am not okay. So I can't. I am not sure seeing all or not.
Okay. Okay, I want to see my patient. If there is any nerve palsy, for example.
Yes, I will send you. You need to see the eye.
Yes, I want to see the eye.
Okay, I pause the timer, waiting for the picture, then we will be back.
Okay. Okay. Okay, let's go back.
Yes.
Okay.
Okay. Let's continue our analysis.
Okay, cool.
Okay. So regarding the headache, you said, can we talk more about that headache? Does it come every day?
I told you it is simple headache like any person.
It's simple headache. So I just want to ask you a few questions about it. Does it increase by bending forward or by sneezing or coughing? Hello?
No, Doctora. No, no.
No? Okay. So do you have any chest pain?
No.
Do you have any shortness of breath?
No.
Do you have any cough?
No.
Do you have any shortness of breath when you lie flat?
No.
Do you have any tummy pain?
No.
Any change in your bowel habit, like loose motion or constipation? Or loose motion or hard stool, I'm sorry. Hello?
No, no, Doctora. No.
Okay. Do you have any feeling sick or getting sick?
Getting sick? No. I'm okay.
Any change in the yellowish of your eye? In the whitish of your eye to yellow?
No.
Okay. What about your water work? If there is any change in your water work in amount or frequency?
No.
Any change in color?
No.
There is frothy urine or no?
No.
Okay. Okay. Do you have any change? Do you have any? Do you have any muscle pain?
Muscle pain? No.
Do you have any joint pain?
No.
Any skin rash?
No.
Okay. Did you notice any change in your weight recently?
My weight is okay.
Okay. Any change in the appetite?
No. Okay.
Do you have any fever?
Fever? No.
Any night sweats?
No.
Any lumps or bumps over your body? Okay. Do you have any difficulty swallowing? Do you have any fullness in your tummy after eating small meals?
Little bit, Doctora. You are right. I feel some fullness after taking.
Okay, I'm really sorry for that. Do you throw up after that or no?
No.
Do you feel dizzy when you stand up suddenly from sitting position?
No.
Okay. Did you have any episodes of low blood sugar, like feeling dizzy or feeling hunger or shakiness?
No.
Okay. You said you are diabetic and hypertensive. Since when you were diagnosed with diabetes?
It's around 5 years.
5 years. Okay. What are you taking for it?
I am taking for hypertension valsartan, for
Yes.
the for diabetes metformin and glycoside, and for lipid ator.
Okay. And for diabetes, do you know how much was your last hemoglobin A1C?
Yes, it was a little around 7.5.
7.5. Okay. Do you have any history of a stroke or mini stroke?
No,
Okay. Do you have any history of heart attack? Do you have any history of heart attack?
no, doctor, no.
Okay. Do you have any history of problem in your sexual life or failure to go, like impotence? What?
No,
Okay. ما قاعدة أسمعك. طيب, do you have any pain in your legs when you walk for a long period?
no, okay.
Okay. Do you follow with the eye doctor regularly for diabetes?
Regularly, once time or 2 times only.
Okay. Do you follow with did he say anything about that?
No, it was early, doctora, at the beginning of the disease, but after that, I didn't follow.
Okay. So do you follow with the kidney doctor?
No,
Okay. So do you have any family history of similar problem, like eye problem?
no, not only like me, diabetes, some of my father diabetes, my mother hypertension, only this.
Okay. Do you smoke?
Yes, doctora.
Okay, so smoking is a hazard to your health, especially in regarding your health conditions, the diabetes and hypertension. I advise you to stop smoking.
Okay, doctor, thank you.
Thank you. Do you drink alcohol?
No,
Okay. What's your job?
I'm accountant.
Is this affecting your job? This
No,
regular vision problem?
no, doctora, how I will work? I'm accountant.
Okay, I'm really sorry for that. I will try my best to help you. I want to examine the patient now. I want to examine you now. If you feel any pain or discomfort, just please let me know. Okay, so I will start my examination by obtaining the vitals. Normal.
Yes, like outside.
Okay, I will start to check the vision. I will start by visual acuity.
Yes, right side, only light. I can see light.
You can
Left
see only.
side, left side, okay.
Okay, then I will do the visual field, but I don't think it's obtainable in this case.
No need.
Okay, so I will proceed to eye movement using the H-shape eye movement.
Yes. As you see, doctora, in the
Okay, then I will proceed for ophthalmoscopy. I
right side, optic atrophy, left side, the mild papilledema.
Right side optic atrophy, left side of edema. There is any signs of diabetic or hypertensive retinopathy?
Mild hypertensive and diabetic retinopathy. The left side more, and right side proliferative, pre-proliferative.
Okay. Then I will. There is any cataract or no?
No,
Okay. Then I will go to examine. I will check for carotid bruit.
no, normal.
Okay. I will auscultate the heart for any murmurs.
S1, SC2, no ultrasound, no gallop,
Okay. There is any basal crackles?
no.
Okay. Then I will do a neurological exam for sensation in the lower limb.
Mild affected the Ben break. Very mild affected.
Dorsal column is intact.
Mm.
Yes. Then I will palpate the abdomen for any enlarged kidneys, for example.
Large kidneys, no.
No. There is no other organomegaly, masses, or scars.
No,
Okay. I want to check the blood pressure sitting and standing.
no change.
Okay, I want to check dipstick, urine dipstick for glucose and protein.
+1 glucose, +1 protein.
Okay, that's great. Mr. What was his name? Mr. Farouk, what is your concern?
Doctora, what about my vision? It will come back or I will be like this?
2 minutes left.
Okay, I'm really sorry, Mr. Farouk, for what you're going through, but you have now a problem in the nerve. What is responsible for your eye movement? So this nerve is affected mostly due to your diabetes, that the blood supply to this nerve is now compromised. So for now, we need to admit you to the hospital. We need to be seen by an eye doctor immediately to check your eyes. Okay, and we will provide you with the appropriate management that we will see. Okay, and this vision, we need to control your blood sugar because your last hemoglobin A1C was high. So we need I would advise you to fortify the blood sugar control. Is that clear?
Okay, Doctora. Another question, Doctora. This vision will come back because some of my colleagues told me you may have a stroke and it will not come back.
Okay. Of course, a stroke is one of the possibilities. We will do some scan to your brain to see if it's stroke or no. But there is a possibility that this vision will come back to normal if treated appropriately. There is a chance that it will come back to normal.
Yeah, Doctora, thank you. Thank you. Does Dr. Basim?
Still 20 seconds. You want to ask any question or to address something important?
Do you drive, Mr. Farouk?
Yes, Doctora, I'm going to my work by my car.
No, Mr. Farouk. For now, I advise you to stop driving until we address this problem.
Okay, Doctora, thank you.
Thank you.
Okay. Time is up. Now the questions. Examiner, start.
Yes, Doctora, give me your positive finding and your differential diagnosis.
Okay, I've examined this gentleman. He was complaining of change in his vision in his right eye. He has clear ophthalmoplegia. He has nerve palsy. Okay. So he also has a history of similar problem 1 month ago with transient loss of vision. Now the patient has double vision in his right eye associated with pain as well. So he doesn't have any positive symptoms in the neurologic exam. He has past medical history of diabetes and hypertension on medication, uncontrolled diabetes, because his last hemoglobin A1C was 7.5. And now the patient on examination, he has features of third cranial nerve palsy. On fundoscopy, visual acuity was decreased in the right eye. He can see only light. And on fundoscopy, there is papilledema in the left eye, and optic atrophy in the right eye. And there is features of diabetes complication by loss of sensation in stalk distribution in both of lower limbs, and he has symptoms of gastroparesis per history. Based on this history and examination, I believe this patient might have third nerve palsy secondary to diabetes. And my other differential would be multiple sclerosis, because this patient might have internuclear ophthalmoplegia, for example. But I need to check if there is nystagmus or no.
Okay, Doctora, any other differential?
It could be from a space occupying lesion, but the patient denied any severe headache.
Against this, no weight loss, no constitutional symptoms. Any
Yes.
other?
It could be vasculitis, but against this, there is no any constitutional symptoms. And it could be stroke, but the patient denies any weakness, and it's associated with pain as well.
Okay. Did you check power and pronator drift?
No.
Did you check any problem during showing? You told me ask about headache only, but any problem in your showing or problem in pain during showing to confirm vasculitis?
What?
Takayasu. You did ask about the showing, any pain during showing, or you feel your vision changed or anything during showing?
No.
Uh, okay. What you will do for this patient?
Okay, for now I will admit the patient to the hospital. First of all, he need an urgent ophthalmological care. He need to be seen by ophthalmologist for this optic atrophy and papilledema, and he need urgent CT brain to rule out stroke. And I will do for him basic lab investigation and specific investigations. As I said, the CT scan for the stroke, and I can send for vasculitis, inflammatory markers like ESR and CRP. And it will be, of course, through multidisciplinary team, including diabetologist, neurologist, and ophthalmologist. And according to the underlying cause, it will be the treatment.
Okay, doctor. If I tell you that MS, this patient is MS, what you will work up?
My workup will be MRI brain to check to look for plaques, MRI brain and spine, and then I will admit the patient and they start IV methylprednisolone and other management for the MS.
Yes, I need the management of MS.
Okay, management in the acute attack, it will be IV methylprednisolone, and then we can give them some medications to prevent the relapses like natalizumab or fingolimod.
Okay. If you start the fingolimod for the patient, any caution or precaution to inform to him or to observe?
Yes, because fingolimod, although it's an oral medication, it can be taken easily, but it can cause bradycardia.
Yes, you will
So
have to greet
yes,
him before and follow his.
yes, I will advise him about the symptoms of bradycardia, and we will do baseline ECG.
Okay. Any other investigation for MS beside MRI?
We can do perimetry for the eye, and we can do what is that LB, lumbar puncture for cerebrospinal fluid for oligoclonal bands.
Especially for eye, any other thing?
For the eye, other than perimetry and fundoscopy.
Related to the nerve,
It could be neurobiolitis optica as well. We can do autoantibodies for anti-aquaporin 4.
Okay. What about evoke the potential?
Yes, we can do evoked potential as well.
Thank you, doctor. Thank you. You did
Thank
very
you.
good job, but you يعني the differential it will be this patient have it is clear MS and I bring it for examination and uh, and management. The patient is telling I have another attack. Once you have another attack, whatever, خلاص, this first diagnosis is MS. His age
Okay.
only male. This is the only little. So he has two attacks of vision problem.
Okay.
And the first time he was transient vision loss. This time cranial pulse, this intraocular ophthalmoplegia. Third cranial palsy, it will come only by intraocular ophthalmoplegia or with some there is some associated, I think, Dr. Basim to confirm for. Then second thing in view of his طبعا this must be mentioned for the patient. Your first possibility in view of you have this recurrence problem, you have a condition called MS, and this is mean scaring of your nerve cables, and you inform him that there is many types, and I hope you are the cause of that cause in the common episodes. And the same after that, you will start the imaging and lab and treat you. Second important diagnosis is stroke. As usual, we are telling that we are all differential diagnosis in basis to be for the most serious, then down to the less serious. So second one, in view of his diabetes and hypertension. So second will be stroke, despite he don't have any weakness, any neurodeficit, but you didn't check the cerebellar. You didn't even do, you told at the end, I need to see nystagmus. طبعا I send the vision, the eye, you should concentrate on the eye. You will see the nystagmus there. Then you will go to complete your cerebellar, check finger, the cerebellar symptoms. He has cerebellar symptoms. So you have a possibility of stroke also. So you will do all workup for stroke during the management. But you will tell that against of that the other no other way. Third one, as you mentioned, the diabetic complication. But also, as you mentioned, vasculitis, but against that, no fever, no severe, no problem showing. His pulse is okay. Also the other one, maybe cerebrovenous thrombosis, but against that, no history of clot for that. So the differential first MS must be informed to the patient, then stroke, then very important also. You didn't ask me this double vision at the beginning of the day, the end of the day. So it must be rule out the myasthenia gravis. You told me any eyelid dropping only, but you didn't mention about the vision. It come which time, maybe fatigability there. And also you didn't mention at all any other preference. Maybe I have a swelling in front, impending graves. So this is very important to rule out. MS, stroke, graves, and myasthenia. And at the end, طبعا you ruled out the infection. Very nice. You told me any stiffness. And at the end, the and venous thrombosis. Regarding the work, as you mentioned, I need to do immediately CT brain to rule out hemorrhage, MR, then after that, MRI brain and MRI spine, and LB and evoked potential. Sharing the ophthalmology doctor will start immediately pulse dose or high dose of methylprednisolone, maybe reached 5 to 7 days. Then, as you mentioned, from Gulomod and the the precaution about that. Education, the counseling is very important for the patient to know what is the prognosis and what will happen later on for him. About this. Workup for cardio for stroke, carotid Doppler and echo and ECG, all also hemoglobin A1C for the diabetes and send him to the diabetic clinic to control his diabetes and his blood pressure. Also during the examination, it's very important. I am telling you this case for examination and the management. You should examine 5 and 7 cranial clearly, and up to 11 and 12 and gag reflex and everything, because sometimes the MS can cause affection of that and the stroke can affection of all this. You did pharyngoscopy, very nice. At least pronator drift should be, if when you go to the patient to rule out the stroke, pronator drift, it will help you too much. Neuro there or not. Also with driving, usually when you feel that you will stop drive, ask about hobbies, maybe have high risk hobbies, tell him to be observed for that. Important
Okay.
also. And full support for his job and that's all I think that I mentioned. طبعا you did everything well, your communication and history, you exclude many of the differential, but very important to put your priority, that's which is the most patient till the least risk for the patient. Okay?
Okay.
Thank you, doctor. Thank you.
Thank you very much, doctor.
Okay,
Very
thank you. Yes, Dr. Kutov, you can comment.
No, I just said very nice, kid. Thank you, doctor.
Yeah. Okay, thank you, Dr. Mohammed, for the case, and well done, Dr. Kutuf. I will comment on the performance as usual, and some comment on the case itself. Cases-wise, if they will bring multiple sclerosis, as Dr. Mohammed said, it's supposed to have previous attack of any of the neurological manifestation. In this scenario was again vision issue, but I'm not sure if they will bring it. They should bring some stiffness or weakness in the limbs, not only vision. This is also an advanced neurological topic. So every MS patient, they will have neurological manifestation in the form of weakness or other affection to the spinal cord, dorsal column.
He has Dr. Basim, he has cerebellar and vision. She didn't check the cerebellar.
Yeah, so there was history of cerebellar affection, but you didn't
Not
ask
history.
doctor.
His history also only vision, but he
Mhm.
don't know about this balance. He didn't mention the scenario. But when
Yeah.
she examine him, she will found that he has some cerebellar there.
Okay, so back to the history. She didn't ask also about the trauma. Very important, Dr. Kutuf, the trauma. Put in your approach whenever you have something weird, put the trauma as a question. It's not a case, but you have to roll it out.
Okay,
Okay. So what do you think the trauma will cause? And what you can add as a differential if you have a history of trauma? Regarding your diagnosis, you mentioned third nerve palsy, right? What is the second differential for third nerve palsy?
Um, it could be some hematoma or something.
Okay. What do you know about the third nerve palsy? There is two.
Yes, it's either medical causes or surgical
Perfect.
causes.
Yes, that's it. What I need. You mentioned the medical cause. The medical cause will be
Like this, for example, for
diabetes.
diabetes. Yes,
Yes, or pneumonitis multiplex
yes,
vasculitis. And what is the other cause or the other category? The surgical third nerve palsy, right? And what
yes,
is the most important cause of it?
Superior aneurysm.
Posterior communicating artery dissection or aneurysm,
yes,
right? So here you have to ask about the trauma. Any trauma to your neck or back of your neck, just to roll it out. And what you will have in the eye, this is a Dr. Muhammad question. The eye will be manifested as
there will be dilatation in the pupil.
perfect. So
Yes,
this is the difference between the medical and surgical one. The pupil will be dilated or mydriasis plus outward downward displacement of the eye of
yes,
affected nerve, right? Here in this scenario, you found the eye is displaced outward. It's not downward, right?
yes,
Maybe this is the clue. It's not out and downward because the third nerve palsy will show the eye will be down and out, downward, outward. That's why the case is different than the third nerve palsy. So we are talking about multiple sclerosis based on the history of previous eye vision affection. And one more question will give you a clue. I wrote it in the chat box. What do you think the most important question if you want to conclude this is multiple sclerosis? When the symptoms appear, the vision or any manifestation of multiple sclerosis, what do you think?
um,
Is there any phenomena explaining?
there is two phenomena with the multiple sclerosis. The one with the movement of the neck. There is spinal shock move feeling. There is one with the hot bath.
Perfect. So you can add to your question whenever you have double vision, only double vision. It's not with or pain eye in the pain, not only double vision because the multiple sclerosis affection on the eyes they have two manifestation or on either double vision or eye pain, right?
Yes,
And it can affect also the color vision as optic nerve affection, double vision or color vision, or pain at the eye, even vision loss as of optic neuritis. Okay, so
okay,
you can add to your approach whenever you have young patients, particularly female, but it's not a rule. You can have also female male patient. You can add. Do you think these symptoms worse with the hot bath? She will tell you yes, or he will tell you yes, doctor. I noticed that. So you have MS clearly. The
Okay.
problem here and what make you confused and distracted you, the past medical history, the diabetes.
Yes.
I thought when you saw the picture, you will catch the diagnosis. However, it was confusing you because you saw the eye is displaced downward, outward. So you suspect third nerve palsy along with diabetes. Actually, it's not poorly controlled diabetes. 7.5 for diabetic patient. It's little bit accepted, right? So it's not
Yes.
explained or justified that it could be poorly controlled diabetes. However, you have the other complication of diabetes like
He has the other
gastropathy.
ones as well.
Exactly.
And he has
Yeah.
retinopathy and if neuropathy as well.
Yes, exactly. I agree with you. It can be, but it distracted you away from or deviated you away from the diagnosis, which is unlucky case to have diabetes
Bassem,
and hypertension. Yes.
to be clear, بس this picture there is arrow there. He's telling you, you order the patient to look to this side, to left side. His left
Okay.
eye is okay, but right eye didn't move. This intraocular ophthalmoplegia, to be clear, yeah. Okay.
Yes. But
Okay.
the other eye will have nystagmus.
This is she didn't ask me. She should ask
Yeah.
me
Yeah.
about three signs
Exactly.
for
Yes. So yeah. So you'll have
yes.
the as a test. You will do the internuclear ophthalmoplegia test. You will have the nystagmus on the in both in the affected eye. You will the eye will fail to adduct, and the other eye will do nystagmus.
Yes. But honestly, if it was a video, for example, I could have picked it. But in the
Yes.
picture, it's not very
Yes.
clear. If it's this palsy, if this one, the affected eye, where is the patient looking, which one is abducting or adducting. So it's not very clear, to be honest.
Yes, yes, you're right. It's difficult, but particularly if you have history of diabetes. So you will go with the diabetic more than multiple sclerosis. So you will not have diabetes and multiple sclerosis in the same patient. It's unlucky patient, and also unlucky candidate to have both condition in one patient.
And a male patient as well.
Yeah,
But
the
what
good.
relation, Dr. Bassem,
Yeah,
patient have once you have an episode before diabetes, he will
yeah,
not give you one episode.
Yeah,
Diabetes,
diabetes as well can cause amaurosis volvox. It could be amaurosis volvox.
can key. Yes, can be.
Diabetes, yes. That's
ماشي,
what I.
you can tell me TIA, but yeah, but this patient is visit since yesterday. He can have
Mhm.
TIA, and this one of the differential. I didn't deny this one of the not differential, but he's now you can tell MS and stroke because خلاص 24 hours بس خلاص the patient is okay.
Okay. And what's the explanation of papilledema on one side and optic noise on the other side? Optic atrophy, sorry. Optic atrophy for optic neuritis. But for the papilledema, what the cause?
Hypertension,
Okay, but
prolonged uncontrolled يعني is hypertension since long time and not controlled. And
But
I
your
mentioned
blood
mild, very mild.
pressure.
I mentioned the mild papilledema, not
okay,
severe.
yeah. So you can say hypertensive retinopathy better than papilledema. Papilledema will confuse the candidate more. She will think about Foster Kennedy syndrome, particularly the manifestation you mentioned. Optic atrophy in one side and papilledema on the other side. That's why I think Dr. Kotov said space occupying lesion, right?
Yeah.
Or
Yes, because of the papilledema.
yeah, so it's this going
It
with
is one of
Foster
the
Kennedy.
differential, Dr. Bassem. This case, MS first one, then do both your differential. And you can both,
Yes,
and we mentioned this during the discussion with Doctora. She told us basically, but again, it's that
yes.
it is one of the
It's
differential, right? Yeah. Yes.
yeah, it's nice case. Really, you have a lot of differential in this scenario: TIA, stroke, along with
But the
multiple
most important,
sclerosis.
Dr. Bassem, this case, it is mainly يعني how you will examine patient.
Mm,
Because if you told me يعني, and this is why 5, 3, 4, 6, you examine. Okay, where is 5 and 6, 5 and 7 and 8? You imagine you can check hair, you can check sensation of the trigeminal, you can check the sternomastoid 11 and 12 and the tongue. Because if it is diabetes,
stroke,
right, complex or stroke, mostly it will affect another cranial nerves.
nerve, yeah,
Not like the MS, it will be straightforward for the one nerve or like.
second nerve or optic nerve.
Yes,
Yes,
yes, optic nerve. Yes, that's why. And the third very important sign for the, and we have now I know we have this nystagmus and the pupil. Mention at all was
yes,
about the pupil. This rapid afferent pupillary defect recurrent lower
Yeah,
rapid.
supposed to be done also, yes, along
Yes,
with this.
supposed to be done. He's waiting for this signs to confirm this. This is you know about all signs of the MS
Yes,
and
exactly.
the other neurological symptoms for other neuro examination for cranial and first for the other upper limb or lower that plantar for lower limb and upper limb. You can do one cerebellar, one sensory, one motor, and خلاص you now it is diabetic complication, it is stroke also, it is MS only, like it will be خلاص. It is mainly for uh, MS and all other differential of stroke, space occupying vasculitis. All this can be mentioned, but only which is the first one and which one the last one. This is the main of this case.
Yeah, I think this is the take-home message. Whenever you have vision comes and goes, think about multiple sclerosis, particularly in the young male or supposed to be female as usual, but it doesn't roll out the male.
Okay.
Yeah, the other thing, Dr. Kutov, whenever you have eye or vision issue, examine the eye, full examination. You know the Afro H shape, right? Afro
Yeah.
H. It's mnemonic for the eye examination. A for acuity, right? A for
Yes.
acuity. F for fields. R for reflexes.
Mm.
And the reflexes here will be pupil and corneal reflex. And you can add to them NO or INO. And O for ophthalmoscope.
Okay.
The H shape. So you will do H shape for double vision. And you can also have the INO positive in H shape movement. So whenever you have eye symptom or vision issue, you have to do these steps. Forget about the peripheral neuropathy. You have to start with the eye examination and do full eye examination. Okay?
Okay. Noted.
Yeah. So let's go back to the rapid or rapid pupillary defect. Rapid, rapid A4. I always forget.
Apparent.
Afferent, yes. R, rapid. So R for rapid afferent pupillary defect. How you do it? Because we are always mentioning it, and it's not clear for some of others.
It's not clear for me as well, doctor.
Yeah, so let's do it. Okay, you will expose both eyes to light. If both optic nerves affected, or one will be affected, right? So you'll start with, for example, in our case today, the left one is affected, right? So
Okay.
you will start exposing both eyes. You will start with the right eyes to the light. What do you think the eye will do?
Constrict.
Constrict. And the left will be from the first exposure.
Normal.
Exactly. So supposed to be midway or constricted. No, it's not midway. It's supposed to be constricted. Why? Because the right eye afferent is normal, intact. So
Mm.
the constriction will be there. Okay. Now you will do the opposite. You will expose the left eye to the light.
Mm.
What will happen?
It will constrict.
No. We finish the first eye or the right eye. Now we'll go to the left. The left will be affected. The optic nerve is affected, right?
Yes.
Suppose initially it will be constricted because of the right eye exposure and the afferent pupillary reflex is intact. But when I go to the left and I start to examine the left, after a while, what will happen? The eye will be dilated because the afferent of the left eye is affected, right?
Okay.
You will go back to the right, you will have it as midway. I hope it's clear.
This means,
So,
Dr. Basim, no consensual, if loss of consensual constriction of the
yes,
other eye, only to lose it. Light.
exactly. So, yeah, you have to start with the right eye. You will have constriction of the left eye. When you go back to do exposure to the left eye, later on, after a while, you will have dilation of the affected eye, which is the left eye. instead of being constricted to the light, because it's swinging of the light from right to left. Suppose to be constricted, still constricted, but instead it will be dilated. Why? Because the afferent reflex there is impaired because of the second nerve or optic nerve affection. You got it, doctor?
Yes, doctor.
So you will start to the right, the constriction will be in both. Later on, when you do exposure to the left, it will be dilated instead of being constricted. This in summary, how to do it. So you are swinging the light between both eyes. Then you will have this reflex or reaction.
Okay, doctor.
Okay.
Okay, clear.
Any comment or question regarding both? And I know, of course, you know how to do it, right? It's shape.
Yes.
Yeah. So it's shape. You will have
Failure of
failure.
in one eye, in the affected
Exactly.
eye, and nystagmus in the other eye.
Yes. If you have both,
We have failure of the adduction in both.
medial lemniscus affection, right?
Yes.
If you have both of them, you will have the nystagmus in both eyes. But
Yes.
if you have one only eye affection, so you will have the action in one eye.
In eye, yes.
Okay. Any question or comment?
Just that this patient had pain in eye. I don't think that diabetes and stroke can cause pain in the eye, right? Even in
No. It's
impulse.
painless. Yeah, it's painless.
So I think
visionless.
the pain is one of the hints as well.
Yeah, so the question of any pain there, it's very important. You can
Yes.
roll out or you roll in a condition. Here, optic neuritis, one of the painful eye loss or vision loss.
Yes, and cataract as well might be one of the glaucoma. Sorry, because he said
Yeah,
he was
glaucoma.
watching some TV, like acute angle glaucoma.
Perfect, but you will have redness of the eye.
Yes, but there is no redness against that.
Yeah, so you have to ask us about redness or pain. These are the questions for any analysis of vision issue, vision problem particularly. I didn't say double vision, okay?
Okay.
Vision will be double vision, but if you have a case of complaint with eye vision or vision affection, so you have to ask all these questions, including the double vision.
Okay,
But
that's
if you have
great.
a question of double vision, at least you know it's double vision. But you have to ask also about other manifestation like any pain, any redness, any trauma, and any dropping of eyelids. Okay, all this related to the eye as a vision or vision complaint. Okay.
Okay, that's great.
Or any other question?
No.
Dr. Basim, hi. I
Yes.
have just some comments about
Good
the
idea,
yeah.
right? Yes.
In the history. So this patient first presented with diplopia. With diplopia, first we need to know exactly what he mean by diplopia. Is it true? Before we see the patient, I mean before the examination, is it true diplopia that by asking some patients may be for if he has flaring of vision, still he said diplopia. First we need to be sure that it is diplopia by asking question like. Do you see two image for the one you see two different images, and then if you close one eye because if diplopia affecting both eyes, the patient when close one eye, the picture will improve if it is
Yes.
affected both eye. If it is affecting one eye, the picture will not, the vision will not improve. So first we need to make sure about this. Then we'll ask about the double vision itself. I mean the picture, the false picture. Is it side by side? Is it horizontal? I mean, or it is vertical diplopia to make sure it is oculomotor affected or it is the third cranial nerve palsy. In this case, it sounds like the third cranial nerve palsy, but first we need to make sure about this. And as far as we think about MS, we need to also to examine the other cranial nerves, because if the lesion or the plaque of the MS affecting the central nervous system, I mean in the brain stem, it can affect the bones and it can affect trigeminal and the patient can have trigeminal neuralgia, and he also may have facial nerve palsy. So this is important to make sure that we are asking about the other cranial nerves.
Yes, we mentioned that. So supposed to examine the other cranial nerve, particularly the affecting the face, mainly fifth and seventh. You're right, but it will be there, Dr. Maida, as a upper cranial nerve or upper motor neural lesion, right? I mean the cranial nerve number 7 or facial cranial nerve.
Yeah, it will be upper motor. Yeah.
Yeah, as upper motor
I mean,
neural.
in the examination, I think maybe I am not sure
Yes.
if she examined that. We need to
No,
examine
no,
it even
no.
in the examination.
Actually, she missed the case as multiple sclerosis. She thought about medical cranial nerve or a third cranial palsy. That's why she missed the part of multiple sclerosis examination and other cranial nerve. But supposed to do, yes, as a stroke one of the possibility, we have to do cranial nerve examination. At least fifth and seventh, these are the most common manifested nerve palsy in the face. You can notice them in the face and you can see them while doing examination. Okay. And you can localize as well the lesion. Is it upper motor or lower motor neuron? Whenever you are doing the seventh, you can know by the forehead. If the forehead is spared, so you have lower motor. So sorry, upper motor. If the forehead is affected, so you have lower motor neuron lesion.
Also, the previous attack, we need analysis for that. He said he has previous attack. We need more analysis about what has happened at that time and if he thought medical advice, if there is any diagnosis before.
Yeah, perfect. It depends on the surrogate. If he can help you or he can just overcome it and just
Analyzed
skip it.
Dr. Bassem. She analyzed it when she asked me what about this attack. I thought I have for a moment I feel I lost my sight. Did you seek
Yes,
any medical advice? I said no, it was a slide, so I saw it's
you didn't ask.
well,
Yeah, you didn't seek
yes,
medical
she
advice.
analyzed it really, and honestly, she analyzed.
Yeah, she analyzed it, but it wasn't in details. Any pain there, any color
Ah,
vision affection.
yes, yes.
Yeah, add to your question, Dr. Kotov, the color vision. What do you think the color vision will be affected in multiple sclerosis?
Yeah, I didn't ask about that. I think
Yeah.
that we read the desaturation.
Perfect. And night vision as well. So add to your approach whenever you have vision affection, you have to ask about these things, the color as well as the night. What do you think the night vision will be affected? In which condition?
Retinitis pigmentosa.
And
And
vitamin A deficiency.
vitamin A deficiency.
Okay, so be be sure you ask about these things. Plus the driving, it's very important. You were about to miss it, and the very important in the welfare point. If you don't ask in about driving and vision complaint, it's really horrible, right?
Okay, okay.
You can miss it in other complaints related or indirectly related, but in this scenario, it's directly related to the complaint. I have vision issue, so I have to address the driving with the question of do you smoke, do you drink alcohol, what's your job, do you drive? It's very important. Okay.
Yes, doctor.
Okay. What? Any other comment, Dr. Maida? Sorry, I was.
Thank you.
Okay. Dr. Muhammad, you want to add any comment regarding this case today?
No, no, no. To be honest, the case was female. I want to check it. Maybe I write mistake. Okay?
It's okay. Maybe if the female will give her, yes,
Yes.
little bit.
But there is much clues يعني for الدكتورة but يعني she concentrated on the
Yeah, because she was preoccupied with the third nerve palsy. Whenever you are preoccupied with something, you will never focus on the other the differential.
I thought
And
once I mentioned I have another attack of sudden vision. خلاص case
no,
was
no. Actually, with diabetes, everything can be explained, like TIA or central retinal artery occlusion, or yes, as doctor said, amyloid fugax. So all of them can be explained with diabetes and dyslipidemia. But in order to have multiple sclerosis and to get it as a basis exam, they should bring it separate. And the patient, for example.
Also, I mentioned only 5 years. It will be the second thing.
Yeah, exactly. This is also another confusing. How come within 5 years he has all this complication? Plus
Well,
the hemoglobin A1C, I told her it's 7.5. It cannot explain. You can say
well, that's
that.
why I make it as a borderline to put it at the second one, not the first one.
Yes, I agree with that. I agree. But actually, sometimes, as I said, if you are focusing on this, you will never find another. So try to be more wide in your differential and you can think about others. In this scenario, I agree it's not diabetic complication because 7.5 it's good for young newly diagnosed diabetes or even within 5 years. You are talking about diabetes complication, Dr. Kotov, whenever you have hemoglobin A1C more than 10, some patients reach to 14, right?
Yes, but the patient already has diabetic retinopathy,
Yeah, this is
has
another.
peripheral neuropathy, autonomic neuropathy.
Yes.
Why he can't have other complications?
Yes. Actually, you're right.
Because all of the complications can come together. So
Yes,
it's
yes, you're right. Yes,
to
you're
be
right.
honest.
Yes. So at least we learned today from
Yes, yes.
this. It's okay. You do good today, really, and Dr. Muhammad as well. Anyone has question or comment regarding two cases today? Okay, I will read the comment quickly. Thank you, Dr. Kotov. This picture, when
Thank
the
you
patient...
very much for giving me the opportunity.
Oh, most welcome, Doctor. I will read the comment quickly. So, yes, I have written this comment to remind myself. Impotence, don't ask about how is your sexual activity. You can say, in good way, I'm so sorry for this question, Mr. X. Any problem in your intimacy or intimate relationship? Okay.
Okay, doctor.
So you mentioned impotence also, which is jargon, how he will know the impotence. So you can
Okay.
ask any question, any problem in your intimacy, and instead of asking about any impotence. Dr. Inas wrote, this picture is when the patient looks right. I think it's NO due to multiple sclerosis. Let's go to the differential. Who wrote the correct differential first? Dr. Zohair, myasthenia gravis, myotonia dystrophica, cranial nerve palsy, multiple sclerosis, gravis, thyroid. So all of them can fit if you have ptosis with myotonia dystrophica, you might have ptosis. Along with also myasthenia gravis, you might have ptosis, but this patient is not having ptosis. So you cannot say this is either myasthenia or myotonia dystrophica. Gravis, if you have exophthalmos, you can put it, but still we are talking about double vision. So it can fit as a double vision. Dr. Ayula, multiple sclerosis, she wrote it in the first one. Perfect. Gravis, multiple myasthenia gravis, gravis of the eye, myasthenia gravis, stroke, mononeuritis multiplex affecting
That
third
in this,
cranial nerve.
as you
Sorry?
mentioned, gravis, and the myasthenia gravis must be ruled out at least by history,
Yes,
even
yes.
before examination. If you didn't mention this both, myasthenia gravis by history, by the end of the day, you feel this
Yes.
or no or any time. And the other, you have any other preferences, any swelling in front of neck, any sweat like this. If you didn't, no, he will decline it because this is a main differential for.
Yes, you're right. Victoria, optic neuritis, multiple sclerosis, perfect. She wrote it. Divic disease. What Divic disease? I'm not sure about it. Divic disease, optic neuritis.
I think this is neuromyelitis optica.
Okay, NMO, okay. Yes, it's the main differential of multiple sclerosis, by the way. You can mention it as a second differential in this case. If you catch the diagnosis as multiple sclerosis, you can put it as a second differential. Retinitis pigmentosa, I don't think it can be with the double vision. It will be vision loss, pituitary adenoma, uveitis, scleritis, glaucoma. So she's trying to write the most common cause of vision fiction. Acromegaly, optic neuritis, perfect, Dr. Inas. So it was optic neuritis, retinitis pigmentosa, Dr. Henry. The retinitis pigmentosa, cranial central retinal vein occlusion, central retinal vein artery occlusion, glaucoma, cataract, myasthenia gravis, myotonic dystrophic, multiple sclerosis, medication induced, perfect. But multiple sclerosis was late, Dr. Henry. It's okay. Acute thrombotic screen, Dr. Zuhair. Okay, this picture, Dr. Inas, this picture is when the patient looks right. I think it's INO. Perfect. I think she catch from the picture. Not looking right, looking left, Dr. Inas. Okay, the arrow with the left side. So the patient is looking to the left and the eye is in nystagmus state. I think INO, okay, due to multiple sclerosis. So you give us the justification even with your comment. Need first to be sure and is double vision. Exactly, you have to ask. Yes, it was with showing for GCA, giant cell arteritis, not showing, it was showing. Ines, Dr. Ines, sorry, okay. Hot bath ortho phenomena, Dr. Ines, I think to be fair, without saying there is nystagmus in the other eye, it's not very obvious, you're right. But you have to do the examination or the H shape to know it. Dr. Salma wrote Foster Kennedy, as I mentioned, it will be optic atrophy in one side, in the side of the space occupying region, and in the other eye will be papilledema because of the brain edema. So the mass effect in the same side of space occupying region, you will have optic atrophy due to compression over the optic nerve, and in the left eye or the other eye will be papilledema as a brain edema reaction. This is Foster Kennedy. It came also before, and we did a case about Foster Kennedy before. It was a good case, maybe a couple of months. Okay, before ending, any question or comment or suggestion? Clear for all? So wish you good night. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, doctor.
Thank you, Dr. Muhammad and Dr. Kutov. See you tomorrow, inshallah, the communication day.